So without further ado, Dr. Block.
Thanks, Ruben. Hope you like it. Prehistoric healers would certainly have had to have been among the most accomplished botanists in ancient times. And whether in the earliest of primitive nomadic tribes or in the advancing agricultural civilizations, and we'll talk a little bit about how cannabis worked its way around the world from an ethnobotanical perspective, if the healers equivalent to today's physicians couldn't keep their plants alive, they would have surely failed at their craft. And they wouldn't have been regarded as a good plant person, nor as a healer. So I love playing in the garden, and I bet a lot of you do. It's highly therapeutic, doesn't take a lot of cerebral thought while you're doing it, but it allows you to integrate with nature. And hence, at UM, about a month ago, I presented at their 6th annual Integrative Medicine Conference, and some of the people coming there who were primary care had big interests in what we'll hear later about nutrition, acupuncture, holistic medicine, and the endocannabinoid system was in fact what integrated and is including the long, elusive brain-gut connection that we'll speak about in a few moments. So what I like to do is I like to start with a slide that really does show how similar we are to plants. And it's not with drugs, it's really with the core molecules of chlorophyll and hemoglobin. And if you think about it, if you look at these two molecules, they're identical. With a central 2+ cation that's a little different, of course, iron in human beings, magnesium in plants. And a plant is really, it's lifeblood in a sense. The plants learned a really good trick long before animals appeared. And you want food? You don't have to walk around and forage for it because plants are existentially rooted. So they figured out a trick called photosynthesis. Imagine that. Take light and make it to your food. That's cool. But here's the clinical correlation. If a doc has a patient who needs their full complement of hemoglobin doing what they're doing, what do? You give it extra iron. How much? As much as it takes till your stool turns black. A farmer does the same thing with plants. They give extra magnesium to fully complement chlorophyll, and it sort of makes sense that way intuitively. You'll see how some of the other things we'll talk about with different plants do the same things because the plants develop alkaloids to protect them, and it stands to reason then that there are certain chemical similarities that we have to plants that, lo and behold, work therapeutically. Now, in this slide here, I try to bring up the differences between what we're dealing with the FDA versus the DEA. Highly relevant in this topic, isn't it? And if you look on top, there's cannabis, but down the lower right, you can see they're both opium from a poppy flower, as well as cocaine. Down the left, you'll see tobacco and chocolate. Those are addicting. How about the bottom middle, caffeine? Everything here has addicting properties. So in fact, when alkaloids were first discovered to really be what they were, it got a Nobel Prize. In 1947, Sir Robert Robertson gets it in chemistry, and I want to just read for you one moment what was taken from his citation speech at that time. It had been known for thousands of years then that plants had these healing and curative properties. So here's what happened in 1947. Post-World War II science, by the way, lent itself to lots of new discoveries, not only in nuclear physics and Einstein that you saw before on the slide, but across all realms of science, including agriculture. So in terms of recognizing the value of what primitive cultures might have had, this was included in Robertson's citation speech talking about these plant chemicals. He said they usually have striking, sometimes sensational physiologic effects. Among them are quinine, cocaine, and atropine, all of which have important medicinal qualities. Plants containing alkaloids have generally drawn the attention of primitive peoples, and in cases where they are met within countries with ancient culture, their knowledge of their properties often goes back to prehistoric age. As such is what exists for cannabis. We'll show that in just a moment. So the poppy and cannabis flowers chemicals then reduce pain perception, we know this, by interacting within endorphin and, more recently described, endocannabinoid receptor systems. When I'm starting medical school, the endorphin system in around 1975 was first described. Go to the early 1990s, the endocannabinoid system gets described. But comparing opiates and cannabis, you'll hear a lot relative to its use for pain. And that makes perfect sense today, especially with the opioid crises. Remember the fifth vital sign, those of you around 20 years ago, and how that was so important? This is from the CDC last year saying maybe we should be rethinking how we authorize, or in this case, prescribe patients to get opiates. You can't prescribe cannabis. Why not? Not even in states where it's legal, because it's Schedule I. So it can be recommended, suggested. Florida goes so far as use the word order, but it can't be technically prescribed. That's the easiest way to get in big trouble. So plants' chemicals are really magnificent. And I'm going to quote this from Michael Pollan, an author, talking about plants, how they nourish us, they poison us, they delight our senses of sight and smell and taste, they calm our nerves or wake us up. And they even change the content of our minds and the experience of our consciousness. These are powerful tools that plants have. And in terms of how sophisticated they are, think of this. The Human Genome Project, all right, ushered in the 21st century of science, humbled us a bit because human beings were found to have about 35,000 genes. Rice, the grain, has been around a lot longer than human beings. Plants figure out their chemistry, how to interact with their environment, and rice has about 50,000 genes, about 50% more than any of you. So it's somewhat humbling from its ability to do this. And yet, these chemicals absolutely have the ability to change our consciousness. I gave a talk last year, and somebody said, "Hey, Doc, scientifically, what does it mean to be stoned?" You think about it. What does it mean? And I've heard someone else say this as well, this author, that, well, if scientifically we don't really understand consciousness, how are we supposed to understand and explain a change of consciousness? So leave that to the poets. This is work done not by poets, but by highly respected, very legitimate MD, PhD researchers from the NIH. This is Pal Packer and George Kunos. And in 2013, this really got my attention. It wasn't about pot, wasn't about the plant. It was about the endogenous system, the endocannabinoid system, that we're now knowing the mechanism of action of how cannabinoids and other associated chemicals we'll talk about later called terpenes work. And they said that modulating the endocannabinoid system activity may have therapeutic potential in almost all diseases affecting humans. I never remember reading something like that in medical school with such a profound statement of impact. And yet the plant itself, for current research, is phenomenally distracting. The subtitle of that previous paper is Targeting the Endocannabinoid System, which we don't have because there's a plant out there. This is the way we're hardwired. Endocannabinoid systems go way back in animals, believe it or not only through all vertebrates, but even in some invertebrates it's been found. The order of 500 million years ago. The plant arrived here about 60 billion years ago, and human beings first documented archaeological remnants showing when human beings interacted is only 10,000 years. So we don't have this system in us because there's a plant out there, and it affects everything. Very distracting if you saw that archer trying to maintain pure focus. There's a little cannabis leaf on the end of the arrow. And if you get distracted by thinking about the plant, your session today with me will not be as understanding of it from really what this works through. I'd like you to try to think along the lines of how you're hardwired and how these chemicals work. So they affect everything. If you look in the top left-hand corner there in green, those are the CB receptors. There are two types, CB1, CB2. We'll talk about more about the detail on how they're different in just a second, but they affect everything. The CB1 receptors are largely thought to be in the brain, spinal cord, nervous system, like that, while CB2, much less is known about CB2, but it's even more fascinating to me because it parallels essentially where the immune system is as far as the physical location anatomically, but they're there and they respond when a disease strikes. In essence, then, they're in us and they're there so that as we age and a disease strikes, your body adjusts its physiology to compensate for that. It makes sense. And if it parallels where the immune system is, understanding the immune systems, they're largely for protein invaders, right? Bacteria, viruses, and the sort. Think of this as a parallel system that we're all hardwired with to deal with the stresses of life and aging. So it also fills another goal. It actually, the endocannabinoid system is that elusive brain-gut connection that holistic doctors, people in nutrition therapy have sort of long thought, what is it that describes it? This is it. Watch what happens in this as time goes on. So how does it work? What's the actual mechanism of how the receptor in this case is different than any of the other receptors you've found and dealt with before? When I went to school, they're teaching a receptor is almost like a light switch, right? It sends the signal from neuron to neuron at the synapse in the middle to keep it going, almost like you think computers, a 1 or a 0 to transmit data. This is not a one-way street. The fine-tuning of what the endocannabinoid system naturally does is it actually has a little feedback loop built in. Because if there are endocannabinoid receptors, there have to be the ligands that we have in all of us that interact with them naturally. The two most common are called anandamide and 2-AG. And what you'll see here is they're actually manufactured on the postsynaptic side. If you see at the bottom of the slide there, sort of in a peach color is anandamide, and 2-AG is there just next to it and with the slightly more turquoise color. Well, they're manufactured on demand constantly at very, very short, infinitesimally small half-lives. But what they do is they migrate to the presynaptic side where they interface with CB receptors. And then from that CB receptors, whatever that particular presynaptic neuron is releasing can be attenuated. I didn't say reduced, I said attenuated, meaning maybe a little more, maybe a little less. Think of that as the fine-tuning loop that keeps every nerve in your body constantly adjusting. And if you want to get an idea just pictorially how that works, take a look here, because people think for the most part that this is a on-off static system. It's not. It's dynamic. Some receptors interactions have the release of things increased from the presynaptic left. Some have it decreased. There's not only agonists and antagonists, there are inverse agonists and partial agonists. The receptors in this situation are highly sophisticated, and their actions are constantly fine-tuning what we're doing. So when did we find out about this? Well, you got to go back actually not that long ago. In the early 1960s to the mid-1960s, we still didn't know what the active ingredient in cannabis, the only psychotropic one, delta-9 tetrahydrocannabinol, THC, what it looked like, how it was biosynthesized. So Raphael Mechoulam, out of Hebrew University in Jerusalem, in the mid-60s was the first to find that out. And the same individual, by the early 90s, was finding the body's own ligands. So now you have not only the metabolic pathway of what cannabis does, but perhaps more importantly, actually much more importantly, how it works naturally in the body. And so some of those studies, some of those sciences now are hard to work with. It's federally illegal. But virtually all big pharma companies right now are working with the body's own ligands. They're similar in ways to THC and CBD, another cannabidiol, another principal cannabinoid we'll talk about in a little while, not because their chemicals look the same. This slide may be a little challenging for you to see in the bottom right corner, the actual chemical structure of THC and CBD, but when you compare it to the body's own ligands on the higher portions there, anandamide and 2-AG, they don't look at all alike. So you say, well, how could they be fooling us, those molecules in cannabis, to work with our own receptors? They have nearly identical solubilities, and they're all lipid soluble. They're not aqueous. So part of the biosynthetic pathway, there will not be a test on this later, but the parent compound on top in yellow, okay, it's geranyl pyrophosphate, GPP there, is the parent compound that derives THC, CBD, and a host of other cannabinoids that we're just starting to find out about. And each of them have unique biochemical outcomes when they're used in research and tested. Very new science, very exciting, And for that matter, very different when the plant chemicals themselves get heated. Combustion, or what you may hear about vaporizing, heating, causes decarboxylation, loss of CO2 from the parent compound, and changes its biochemistry. Of all of these chemicals listed here, the one in the bottom, THC, is the only psychotropic cannabinoid, and yet when it's heated, it changes. When its acid form then is changed from THCA, which would be if you could read right above the gray box on the bottom, to THC, it becomes psychotropic. And many people are familiar with those outcomes of it. Full disclosure, don't use. Need to know about this simply because those people who grew up in South Florida maybe 50 years ago, they didn't know about it. They were probably growing up under a rock. It's everywhere. It's always been everywhere. And it's still there. But now our patients are actually coming to us with intelligent questions. New laws in Florida changed as of last week. Try to keep up with the slide content if you have that dynamic of a field. And they're bringing intelligent questions. There are going to be some interesting answers that we should be able to provide for them through educational forum like this. This here is not simply restricted to the biochemistry or hybridizing of a plant. The 21st century has and will continue to be regarded as the essence of the entrance of genetics. And so the genetics of the plant as well as people are now being researched very heavily. How the plant started to get, though, a little more into modern culture with knowing some of these medical benefits was popularized about 3 years ago by Sanjay Gupta in CNN. And here's a quick little remnant from one of the shows there that he talks about just what happens and why the whole plant in combinations of chemical have evolved over time to probably be more representative of a balanced effects than single chemicals that get extracted.
It's especially good for little kids who are taking it as a medicine. No matter the method, THC goes through your bloodstream and into your brain. And there, the THC is going to latch onto these special receptors. When they are stimulated, you release dopamine. It sends signals to various nerve cells all around your body and makes the user feel high. Not all cannabis is going to get you stoned. That's because marijuana contains another chemical known as CBD. That's cannabidiol. Marijuana plants that have low THC and high CBD can work really well as a medicine. They can treat things like epilepsy. It works because the CBD chemical can quiet excessive electrical and chemical activity in the brain. I know this 3-year-old girl who went from having 300 seizures a week to 2 per month after her parents gave her cannabis with high levels of CBD. When it comes to marijuana, there's some 500 different chemical compounds. All these compounds work together. It's something known as the entourage effect. It's important because you can't just take a chemical out of marijuana and make a medicine. You need the whole plant, especially when it comes to using pot instead of pills.
So, anybody remember ever seeing these interviews a few years ago where he does a mea culpa and he says, you know what? I went out and I learned about it, and it does seem that there is medical value. That was a watershed moment. And so, in fact, we've had a change in how education, media, and industry is encouraging to know more. Mainstream magazines in terms of bringing out information like this the last few years, and even the NIH with absolutely beautiful research that's shared. This is open data sharing, open access things. Any of you can pull this up. But yet, somehow we're still stuck with this as primary care physicians. This doc actually has the FMA logo on him there. I'm a member, many of you may be, and yet this was before Florida's first constitutional amendment was being critical of how are we sharing what information with patients and at what outcome. So here's what the outcome and where things are today. This is different as of just a week ago, but this is a current map of the United States reflecting not only which particular states have medical cannabis that's now legal in that state, but which have advanced to what they're calling now adult use. Not recreational, God forbid kids should get it. This is the way that it's being promulgated throughout the country. Those stars through there are those states that had measures this last election cycle in November, including Florida, which changed its law from previously only being about CBD, no THC, and now it's a full spectrum. So in fact, the laws are changing quickly, rules are changing quickly, and so it's a very dynamic process in sort of the same way that in reverse that cannabis went into prohibition back in the 1930s. It started in California around 1910. And that was simply a historical event that happened, Pancho Villa, invading from Mexico, but not Mexican government, actually a terrorist in essence, taking over U.S. land and killing Americans. So in an effort to segregate itself and be, more enclosed, cannabis made it illegal there in California around 1910. By 1937, 27 years later, it was the law of the land with the Marijuana Tax Act. Coming out of prohibition, if California, again, may be setting a trend, you go back to the mid-1990s when their first medical cannabis access was promoted. Now we're 20-something years later, and there's a general understanding that maybe it should be not Schedule I, but perhaps controlled substance. There's people who would like it to be completely descheduled. These are political conversations, but they're what are causing your patients to bring to you those intelligent questions that they bring. So what are you supposed to do? You're stuck. And that's where we're at today, but the education is going to let you figure out how you balance just these things. So what I'd like to do now, I want to go to a case study. And I want you to think a moment as we go through this particular case study. Is this somebody you think should get it just from what you know already? All right, you're a savvy group. You're coming from a part of the world maybe where you know it's out there. So let's look at this a minute. A case study about a lady named Marilyn. She's 68. She's got breast cancer. It's metastatic to her lungs and the thoracic and lumbar spine. She's currently undergoing chemotherapy, doxorubicin. She reports having very low energy, minimal appetite, and substantial pain in her thoracic and lumbar spine. So she takes for the release of nausea, let's say, I can ask you the long names, but I've written it down here on the slides. She takes Zofran and some Compazine, and so not really helping her. She's still nauseated. And she's also taking, acetaminophen Tylenol every 8 hours for pain, and sometimes at night she takes 5 or 10 milligrams of oxycodone, but remember, she's not getting good pain relief. So what happens is she comes in and she sees you, and she says, what do you think about me using marijuana to help alleviate the nausea, pain, and fatigue? And she lives in a state where it's okay. I've taken this case study 3 years ago, right out of the New England Journal. You can apply it here. So how many of you, just a show of hands, in terms of how you would treat her, what would you say to her? Would the first thing you say to her, since she's asking, is, yeah, I think we should try that, and then say, go try it and let's see how it works, come back in a month. Anybody? Anybody go that way? We got about a third of you raising your hands. I'll assume another third are just shy, but we got people who said, yeah, they do it. Well, I want to bring up this perspective now, because marijuana is not a first-line treatment really for anything. And the reason I'm bringing this up with the evidence-based data for what it really in 2017 shows that it works for is, one of the things is pain. But in fact, Marilyn's pain is from metastatic cancer to her thoracic and lumbar spine. She needs to be irradiated. This is secondary. So the cause of what the symptom of pain is the key thing to hone in on. And it's not to say that it couldn't possibly help as an adjuvant treatment, perhaps even not to make any less opiates that she may need. She's not helped with opiates, and she's nauseated on top of that. So my fellowship's in pain management, but back when they used to teach it along with addiction medicine. Then it went the way that addictionology went the way of psychiatry. But as an anesthesiologist, we're still the purveyors of interventional pain management. Feel free to talk to your other colleagues about how you would treat this patient, and should we include cannabis or not. A few years ago, I authored the course that docs have to take. I believe there's about 800 docs now who have taken it through the Department of Health. I don't know if anyone here has. But education on this from 2 or 3 years ago now is outdated. So I'm really glad that you're here, because here's what you need to know today of what's available. This is the entire formulary of what you could get regarding cannabis today in the world. Some of it's the plant, some of it's single components of the plant, like THC in what's called marinol. On the bottom, nabiximols is an extract of the same plant, but to extract CBD, the cannabidiol that you heard in the slide before, could be so helpful, and it is not psychotropic CBD. Its side effects are minimal, if any. Only in extraordinarily high doses do you see some side effects from cannabidiol. So in looking at the alternatives, look at that right side column. The first ones are Schedule 1. No, you can't do it. In states where you can, again, it's federally illegal. But you do have other things, Schedule 2, 3, and other things currently under FDA research right now. So while there are choices, those choices are not bringing up really what the full chemistry of the full plant's chemicals would offer. So what's a poor doc to do? Well, this is what you're up against, because industry, in essence, is driving that cart, but maybe in the wrong direction. Your docs, you need to know this. Answer to your patients with the science and the reason that's behind it. What's the reason now? Well, probably something that has to deal with ethics. So I'd like to cover with you just for a moment, how do you answer this question when you're the practitioner? Should a physician offer compassionate access to cannabis while it's under federal prohibition? And the AMA has guidelines on this. If you're going to look at this from a medical legal perspective, what the current AMA guidelines would say is that a physician shall respect the law and also recognize a responsibility to seek changes to those requirements which are contrary to the best interests of the patient. Sounds great. Hard to do when this is federally illegal. Why? Many of you, if not most of you, have two licenses. Not only the license where you're permitted to practice in a given state to follow that state's guidelines, but you have a DEA license. Not only is there a precedent that with deviating from what should be expected that you could have risk to that DEA license, but the reality is very few mainstream docs in 2017 are fully prepared to see patients who want cannabis because they're afraid of losing that tool bag. Now, when I get much older and I may need something in my doc's tool bag, I hope they have access to everything that could be imaginable to help me. But in the meantime, we're law-abiding citizens and practitioners, so that's one big confounder. The second confounder that makes it so most docs are not necessarily inclined to jump right into this is that most states have gone about setting their new laws by doing two things. First, saying which chemicals you can use and for which qualifying diseases. I don't know about you, but the last time I looked, that was called the practice of medicine, and docs understandably are going to push back to being legislated the practice of what you're licensed to by unlicensed legislators. So there is resistance, but that will find its own level through education and research into the very near future. A lot of it's going on. So let's go way back then and realize that the ancient healers, they dealt with traditional botanical wisdom and compassionately shared their knowledge for health and survival. Not only in ancient Asia, but ancient Egypt. This would be Imhotep. If you know the origins of the history between Hippocrates and Imhotep, actually documenting, writing down the evidence so that there's a history that the people that followed them and will follow you could really know what works. And so even Hippocrates says that nature itself is the best physician. Well, I got a chance to give the oath of medicine over at UM. And to tell young docs right from wrong is key. And they actually listen when they hear reason. It may not be medical, legal with all the solutions about that ethical dilemma of should a doc do that, but it's almost harder when you've always been trained all your life about cannabis being illegal, there must be something wrong with it, to unlearn something perhaps that you are welcome and open to learning something new that may be factual. So what happens then is that we still abide by the letter of the law. Because it is federally illegal, the standards on physicians who venture into this to authorize patients is being set at a very high level. The Federation of State Medical Boards, the overseeing site entity on all medical boards from states and commonwealths, came out with this advisory statement last year. And it says that basically, if a doc's going to go ahead and authorize patients to get it, they should not themselves use it nor authorize family members to get it. And that's the position right now of that entity. So I'd like to approach this whole dilemma a moment from a bioethical perspective. It's different. And those of you who have ever been involved with bioethical discussions know that bioethics also evolved after the end of World War II, when there were questions about things that we didn't know to ask before that were relevant. And you don't have to go back 50 years or more to look at that. You have to go back only a decade and look at stem cells, which when this permitted lines first came out and we were afraid of using something for nefarious purposes, it took a bioethical discussion to get past some of those initial constraints, which are limited stem cell lines. And you look today at how that technology and science has advanced. It got through that kind of a position about a decade ago. And for cannabis, since most cannabis, if you look across the country, about 80% is authorized to patients for the single diagnosis of pain. And I'll tell you as a pain doc, pain is not always anatomical. It is not always organic. It can be psychological, and some people even spiritual pain seeks relief. So for a bioethical position, this is not a compromise statement. This is meant to be something that would be otherwise irrefutable from the perspective of a patient and their healer. And so this is something that, because it's a bioethical process, involves the whole community, not just medical legal, not just doctors and lawyers, but inviting people to bring this up. And so what we've come up with is a statement that says seeking relief from the physical, psychological, or spiritual symptoms of disease is an instinctual force of human nature, and it may contribute to medicinal use. And then from the doctor's perspective, though, the treatment of intolerable symptoms is an honorable task that a society bestows upon its healers to provide humane relief. I choose not to get stuck in the medical legal part of it and just think of it more as a common sense way to work through what's been a problem for about 85 years in some form or another. So let's get into the plant, the chemicals, where in the brain it works, and these are the things you'll be very familiar with pot does. In particular, in the middle there's the memory and the reward centers, the things that make someone who uses it feel good. The fact that effects on memory are very well known. It is not a performance enhancer. So in terms of how it affects the brain, remember, the brain is mostly those CB1 receptors. CB2 is the gut. And I'm going to present you a series of slides now, which I think will give you great insight. But what you'll need to do as we go through these next slides is don't think about it from the perspective of there being a plant. Think about it in terms of why would we be wired this way to begin with from the endogenous system. Very few docs understand this now. So if this resonates with you, and I'm hoping it will, because we're sort of short for time today, I'm going to move along with it. Feel free to contact me afterwards or in the social event tonight, because this is a huge subject. When you realize all that can figure into this therapeutically with manipulating that endocannabinoid system, the same thing that first research paper said it has potential to affect nearly all diseases known to affect mankind, this is where it comes from. So the most frequently cited researcher in the world on endocannabinoid science is Vincenzo Di Marzo. And back in 1998, he said, relaxing, eating, sleeping, forgetting, and protecting. Relax, eat, sleep, forget, and protect might be some of the messages that are produced by the actions of cannabinoids, alone or in combination with other mediators. We'll talk about those other mediators later. It seems that the smells that are in plants and odors actually do have effect in combination and synergy. So I wanted to put this in perspective in that if the target is in fact the endocannabinoid system, and if we are born with this, then from conception all the way through death, let's come up with a model for how it really works. And there are 5 things then that we just talked about. Remember, relax, eat, sleep, forget, and protect. that's what I'd like to build around here with you, understanding what the system's designed for. And let's just make a simple statement in terms of health function, that it's designed to sustain an organism by adjusting its physiology. I say an organism because this is not a high evolutionary evolved thing that's unique to primates like us. No. Invertebrates, okay, sea squirts in Tampa Bay is where they found this also in. So just because it's newfound doesn't mean it's not integral to the way we're wired. So what I'd like to do is introduce then the 5 things that I just told you, where the first 4 are things of CB1, brain, nervous system, eating, sleeping. Those were 2 of the ones we cited. And so if you want to think about the eating and sleeping, then remember the next 2, which are really brain-type things, relaxing and forgetting. Forgetting is going to be a fantastic little talk we give in just a moment on it. But there was a 5th one, and that 5th one is down on the bottom. I put it here. That's the CB2 receptor's function on a fine little pivoting, balanced little triangle there that keeps us from dying. It's there to protect. And so let's go through these a moment in terms of eating and sleeping, because when people want to know what's it all about, it's this. Imagine if you couldn't be hardwired to effectively eat and sleep. Imagine the effects on growth. Imagine the effects on reproduction without having an innate ability to fine-tune when you really need to eat and sleep to grow and stay healthy. So the next one's relaxing and forgetting. Don't think about the plant now. If the last slide you were thinking munchies or people using it when they go to bed, sure. But in this case now, again, relaxing. This guy's chilling, isn't he? Okay? You don't know what he might have had before, but that's natural. And you have to do that. That's to recover. The other thing, though, that I said was really fascinating was the CB1 receptor's effects on the hippocampus. That's where memories are stored, new memories in particular. And that's where the THC and cannabinoids have effect. It's not going to help you study for your boards, okay? But it's there for a reason, because that particular part of the brain being fat, I showed you in the previous slide, does have a lot of THC that goes to it to affect the receptors. So why do we have to forget? You know, people think, oh, well, I got to remember everything, each of my patients' numbers, the diseases. Imagine if you had to remember the moment you left this room, the first, last, and middle name of everybody seated in this room right now. You have to have forgetting for a selective filter. We all have it. We all do it. We need it. But in cannabis, I just told you before, it's used most frequently by patients who just know it helps pain. Not necessarily physical, but think about it. And obviously the pleasure side. Think about a moment what happens in terms of your psyche with respect to pain or pleasure if you can't forget. Hey, Mom, if you couldn't forget the extremes of pain of childbirth, you think you'd have another one? You think we'd have a word in our language for the word brother or sister? We'd all be only children. So there are therapeutic reasons that certain things that are painful are forgotten. That's got nothing to do with pot. How about this? Let's pretend a moment that it's 5,000 years ago, and the beautiful beach that's outside, we're just a nomadic tribe, and we're foraging around for a fish there, or maybe turtle meat. And out of nowhere, some wild beast that used to exist here comes and chases us. Think a wild boar, okay? But think prehistoric, like the size of a Buick. Scary. So it pushes, we run away, we're climbing up in a tree, our hearts are pounding, full sympathetics are going, and nightfall comes, and that beast is going to go away, or something might eat it. We're not nocturnal, we're going to stay up there ourselves, but imagine if the sheer terror of that moment couldn't get out of our minds. The next day, we're up there, that pig's coming back, 2 or 3 days of that, and we're pig food. So we have to be able to effectively forget. Think PTSD a minute. how disruptive that is when people can't forget something, sleep in particular. We're hardwired to be able to forget those extremes of pain. And if we're hardwired to forget the extremes of pain, how about extremes of pleasure? That same 5,000 years ago tribe here, okay? You think they're growing pot outside, or they have sugary drinks, or internet, what other addictions, gambling, No, we're just trying to eke out an existence. But there's sex. Now think about not being able to forget pleasure in an ancient time. And how did human beings derive pleasure? Think sex. So what happens then in 10,000 years ago? You got caveman Og, and he's always lagging behind the group as they go in their nomadic way, hanging out with Lady Pleistocene, and they're always going at it. Now, if you were a saber-toothed tiger, which two do you think in the pack would be the easiest to pick off? Because they couldn't forget the extremes of pleasure. Forgetting is wired in us in very unique ways, both from pain and pleasure, but it is a dangerous intersection. So that covers the brain part of CB1 receptors. I like the model, though, because it gives you insight, giving you reference through maybe the way you think of cannabis. So what about the last one we talked about with respect to the CB2 receptors and protecting? Remember I told you before about how the CB2 receptors lie dormant and then appear where there's a disease. And you can track this out. You can radioisotope label the cannabinoids and see where they go in a different disease state. And in this case, it is about protecting. So when you're thinking about protecting and understanding those chronic diseases come along, they may not be the things you necessarily need early in life, but later in life, absolutely. So what do the CB2 receptors, what are they known to mitigate? Guess what? Inflammation, tissue injury. These are all very well known. The gut is lined with them. The gut biome is all about the endocannabinoid system, the microbiome. And here's a really cool slide that I like. I put this together a few years ago when I took an acupuncture course. And it was the first time I was really understanding more about Eastern cultures, the way they understood health. Anybody know what chi flow is, the way that, we integrate with our environment? In acupuncture, the ancients never thought that health goes through the brain or the heart or the lungs. It's all the gut, all abdomen. So all those little points of acupuncture points on that ancient acupuncture chart, look to the right. The same distribution for where CB2 receptors are. If you look right above the word life there, you can see on the arm a tiny little point where the intravenous site was on, where they radioisotope labeled, and they did a PET scan, finding where those cannabinoids went to CB2 receptors, and everything that lights up, not just the red, that's more blood flow, but any of that yellow, green, abdomen, are where these receptors are. It's a blueprint smoking gun for the endocannabinoid system and overall how we interpret health as we age. So the ancients knew this, but they knew it because we can actually do archaeological studies to find that human beings have been documented to have used cannabis for at least 10,000 years. It started in places in Asia. That's the Himalayas in the middle, that red blob in the middle there. That's what's called a refugia. Refugia were places in ice ages that stayed warm enough and wet enough for certain animal and plant species to survive. And there's a smaller refugia all the way to the left, closer to Europe. This work was done several years ago, 2013, on the ethnobotany and evolution of human beings in cannabis. Cannabis starts here in this part of the world, and then over the next 10,000 years, it's used in cultures with archaeologic evidence, hard data. 700 BC, a tomb in China of a shaman, and not only did those two bowls have cannabis, but they actually had female cannabis flowers, which is where the greatest concentration of active cannabinoid chemicals are found. Why would they pick just those and have those there? This has been known for thousands of years by ancient cultures, just like I told you, Sir Robertson's citation speech referenced. So then over the next 10,000 years, cannabis and hemp. Remember, we're talking a plant that has two forms. One is the mind-body drug substance, but the other is actually a textile. Columbus's ships, riggings, and sails were made of hemp. If you wanted to be a landowner in colonial America, you had to promise to grow hemp. Washington, Jefferson, they all did. And until cotton supplanted it, hemp was a big industry. It's making a resurgence now, but technically it's also federally illegal. So what does cannabis really look like, the plant itself? Guess what? It's a big plant. That's not bamboo. That's actually real cannabis. That's a 20 to 22 foot plant that grows in one growing season. Those long stalks are sources of fiber. The leaves and the seeds actually that get into them could be pressed for the oils for different chemicals, but cannabis is a 22 foot fully grown plant. And yet that's not what you see today, is it? You've seen pictures of where they're growing? What you're seeing are all descendants of this plant from the early 1970s, found in Afghanistan. Richard Evans Schultes, ethnobotanist from Harvard, realized that this plant in the Kush region of Afghanistan, it was a 4-foot squatty plant, produces a lot of psychotropic THC, a particularly hypnotic terpene, it's called myrcene. And those are the dominant genes. It's hard to find plants today that don't have these parents in it. Why? This is a 4-foot plant. The other one's easy to see from a helicopter. It's illegal. So this is the plant that pushed everything to be today what it is as the modern plant. Stronger than it ever was when many of you here were kids. Certainly stronger and no longer representing the chemical balance that used to be in the plants. And so in fact what we have then is something that is absolutely much more concentrated and brings about tolerance and dosing. And if you don't think this is important about controlling your dose, think about this from 1978, and you get an idea for the caricature of it, okay? Yeah, it's funny. Cheech and Chong are really funny. 1978's quantity, and in the 1970s in general, of where the plant was in terms of its concentration is very different than today. Today's plant, in fact, having both cannabinoids and terpenoids, those chemicals are made on the ends of these little structures, all the frosting on that flower bud from a female flower, that when you look in close to it, like up in the top left, they look like little golf balls on tees or little mushrooms. That's where the chemicals are. If you rub those off and extract them and make them into an oily paste, you get hashish, the concentrated forms of it. But the key here is that compared to the early 1970s, where an average cannabis plant may have 4% THC, now it's been pushed well over 20%. But think about this a minute. Alcohol prohibition did the same thing. Anybody know what the most common alcoholic beverage was before alcohol went into prohibition? Somebody said beer. Right. Why? Well, to begin with, fermentation kills the bacteria in it, okay? Impure water today and back then kills more people globally than anything else. So yes, water purification, and also calories. We didn't have all the grocery stores and the problems associated that we do today. With too much food, it was a source of calories and pure, clean water because it was only, beer again, about 4 or 5%. Alcohol, it was something that was in everybody's diet and used presumably responsibly because you had to have something like that. The moment alcohol prohibition hits, you see Al Capone rum running. More than that, you see moonshine, right? Well, in a sense, some of the cannabis you see coming out today, and we're talking about in the states where it's been legal and has been advancing, is the moonshine equivalent of cannabis. So I said there was another chemical in the plant besides cannabinoids. Terpenes are in all plants. They're the things that the plant uses its chemical genius, in a sense, to make that allows the plant, by being rooted and fixed, to interact and interface with its environment. It may be something sweet to your smell, but to an insect that wants to pollinate it, it's like, come here, come here. It's an attractant. You have other things in the plants that are very often in the alkaloid families that are meant to be anti-herbivorous. Animals taste it, they don't like it, or maybe poisonous to the animal. And that's why most medicines, take a spoonful of medicine, right? Sugar with the medicine go down, they're bitter. They taste bitter to the animal, they taste bitter to you. Those chemicals that the plant derives have reasons. Those that have smells and odors are the plant's extension of its existential liability of being rooted. So The different smells in them have different properties that are very well known to determine outcome and effect on the person who's using. The one that I told you that was perhaps, in my opinion, the most one to be concerned about, myrcene, is the dominant gene that also came from that older squatty plant, and another variety. That was Afghani Kush number 1. There's something called skunk number 1. Guess what that smells like? Those are the two varietals that have lots of myrcene. That's actually not simply calming or sedating, it's actually hypnotic. It puts up that wall. That's the stoner's high. As a matter of fact, you can go to Bavaria and still find places where they will stuff pillows with the closest genetic plant to cannabis, hops. What you put to take a whiskey and make it a beer, hops, has lots of myrcene also. And when they're put in pillows, it was to assist sleep. So perhaps something that has a higher amount of myrcene might be okay if it's used for sleep, but come time to get up and go to work, that's not your medicine. So what are we talking about then when you extract and push the plant to be unbalanced and try to take something and make it something that didn't evolve with human beings this way? It's this nice statement here, and it's, a little out there, but Deepak Chopra said that isolating an active constituent from a plant is an affront to nature. It's like taking the intelligence and leaving the wisdom behind. So if you look at the plant today compared to what was around 40, 50 years ago, this is what you see. In the middle of this chart, I've written down what you would also find if you went to find some landrace fields. Landrace fields being ancient fields where cannabis was grown, where it develops in response to two things: the cultural constraints of what it's grown under by the people using it, as well as the environmental conditions. So landrace plants reflect just that. Landrace plants from years ago, you can still find them in the Bekaa Valley in Lebanon, is a good example. Those plants had an equal amount of THC with that cannabidiol, that other chemical we talked about that Sanjay Gupta said, that's actually pretty interesting. It seems to have therapeutic effects without being psychotropic. As a matter of fact, if you look at people who get into problems with unbalanced plants, especially a naive user who has a plant having a lot of THC but not much CBD, will very often behave in a paranoid way. It's actually a bad trip. A few years ago, a New York Times correspondent, Maureen Dowd, wrote about just that when having an edible where she had it and then spent the next freaky several hours in her hotel room freaking out. I'm going to share with you an occurrence that happens when a naive user doesn't have a balanced plant, because what the CBD part does, the CBD is actually a very effective anxiolytic. So when it's combined in balance with something that could provoke anxiety, the THC, you have a mitigating effect that way. And that's important, because what happens is that not only is the plant consumed in balances, whether it's smoked or what they call vaporized vaped. By the way, in Florida, smoking at this moment is illegal. Vaporizing is an acceptable rate of administration, although most of the companies now are coming out with certain oils that could be taken sublingually. Edibles, though, when you ingest, the THC undergoes a change in the liver, converted from delta-9 to hydroxy-10 THC, and its effects last perhaps 3 or 4 times longer and are 3 or 4 times more potent. That's a problem. Especially what happens is when you have a naive user experience that, and a frequent outcome, or a frequent occurrence. I'm going to give you the example. A young couple goes out to a party, okay, boy and girl. Maybe the boy's experienced smoked pot and knew it to effect. Girl never did. They go to the party. Everybody's happy, eating, and it's just part of it. And the girl's never done it before, naive and never accustomed to it. So somebody says, here, try this cookie or this brownie. Well, there's a huge field and industry producing edibles. But remember, I just said, when THC in an edible, especially higher doses, a naive user, when they have it, it may not produce something that is a good trip. So the party goes on. Maybe the young girl tries a little one, cookie. Well, the onset's much longer. Instead of being like 5 minutes, that if somebody's smoking or vaporizing, could be up to half an hour before the onset of any effects are appreciated. Plus, the dosing in a naive patient may produce more of that effect. So if nothing happens, hey, it's been 15 minutes, I don't feel anything. Well, have another one. So half an hour goes by, and now the effect's coming on. But unlike everybody else who may be either used to it or is only smoking or vaporizing with it, when everybody else is getting ready to go home, her trip's just starting. And she's behaving bizarre, really paranoid, crying tears, friends around her maybe thinking, oh my God, maybe somebody put something in her drink, or maybe she's allergic. So they do the responsible thing. They go to the emergency room. And if it's here in Florida, by the way, and they do their due diligence as far as checking out if there are other things that might have been in a drink, other toxins, other chemicals, get a urinalysis, blood. You find it in somebody here, and now she's a felon on top of everything else that's going on with her. Plus, maybe getting a psych consult as her visit to the ER continues. And then, of course, the friends or the boyfriend bring him and have to call daddy. This is a scene that repeats itself not infrequently in an ER. And people who use edibles should be very, very cautious because it's not the same chemical for the end result. Some people, though, will use it. Little pieces of chocolate are made with it to assist sleep. That may be fine. But be very cautious about people who do not know about the effects because they sometimes show up with that kind of history. So you can find out, in fact, what is in this. The biochemical profiles are available in many testing labs, mostly on the West Coast. But until the states individually mandate the full disclosure of what's in the plant, not only cannabinoids, but those terpenes I said that together determine outcome, a doc's not going to really know what the cause and effect are. We'll find it very challenging to authorize or recommend something versus another strain because they all vary. And so to have the full disclosure of what's in the plant is absolutely essential. Don't let anybody tell you, oh, well, they don't tell us what's in it. It's their intellectual property. That's where any semblance to a pharmaceutical ends. And has anybody been in a dispensary anywhere in the country to see it? All right, it's a little bizarre, okay? Because you go there, and it's not like a pharmacist generally behind the counter. They're called bud tenders, the bud of the flower. And yeah, that's true, right? And imagine the experience if you were to go in there and see jars lined up with a name on the jar, you know, Cushy, Snoopy, Doggy, with maybe none of those active cannabinoids or terpene content in there. Someone tells what it's like by smelling it. Now, smelling is actually very important. It works deep olfactory. It gives you a sense, is it good for me or not? It's hardwired in subliminal ways, and it probably is valuable. But imagine the pharmacy experience if you were to go into a regular pharmacy. So just for this quick little exercise, imagine if you had a jar of cannabis, but instead it's Valium, and lots of these little pills are there, and lo and behold, it says 1,000 Valium. You smell it. Smells like Valium. But here's the disconnect. You tell the pharmacist or bud tender, I'll try one, and if I like it, I'll come back and get some more. That's the disconnect to a real pharmacy. So the overall lesson here is start low, go slow, and that's the key to this. Remember the tortoise in Finding Nemo, the stoner turtle there? So the dosing incrementally build up at very slow intervals. The only multi-combination combined medicine now called Sativex from GW Pharmaceuticals and the Biximols. It has that one-to-one balance equal between them, and the dosing starts baby doses and builds up. No effect after a couple weeks of slow building up, failed test. That is exclusively there for multiple sclerosis muscle spasms, of which about 90% of patients having that get them. There is therapeutic value and merit from the FDA, from the National Academy of Science, Engineering, and Medicine studies came out just in January, saying that there are 3 qualifying diseases that have evidence-based data today, and that's one of them: multiple sclerosis muscle spasms, chronic pain, and the third is the nausea and the vomiting from chemotherapy. And I'm going to extend that to be HIV and AIDS. We've talked about that before. Basically wasting syndromes to promote appetite. So that, in fact, is what happens. We're going to wrap up now with where I told you this is going to, genetics. Imagine now 21st century human and plant genetics. These individual lines represent a specific cannabis genome that's been deciphered. Now, this is taken from about a year ago. The first cannabis genome wasn't done until 2011. And by 2015, now you've had about 150 or more. And if you look, there's certain common lineage in the different plants. Because remember, we dragged it around the world, we changed it. This is what it's at today. Well, imagine, everybody know CRISPR technology? This is future now. Imagine if you could recreate what was back there hundreds of years ago, but not just in this part of the world. Remember, there were Indian subcontinent, Asia, Africa, lesser in Europe, but there too, all around the world, but how humans might have evolved. Because now we're such a big melting pot, what may be good for one person may not be ideal for the next. This has been in human cultivation for 10,000 years. I don't want to think that the last 30 years of how we've screwed up the plant should totally disqualify 10,000 years of maybe at least a teleological suggestion that it works favorably with our genes or it might have been extinct. Isn't that the ultimate knockout experiment in evolution? So in this sense now, if you could find the ancient and ancestral roots, so to speak, but of the genetic code, what about if you could recreate those older plants? The reason this isn't so far-fetched is because global communications make this efficiency far more efficient than it could have been even a decade ago. And not only that, there's a synergy with the sharing of scientific data. The NIH's shared access. The Human Genome Project is shared worldwide through the internet. So you know you can't bring as much as the seed from here across the state line to another state, but to advance the science, do you know what you can share to recreate a plant, not to rehybridize? Code. You press a mouse button and you send code someplace where if they have the same technology, the plant's everywhere in the world already. So imagine if things could be done that way to change it. So to finish up then, this is the indulgence temptations offer. Think of this like those sugary drinks, gambling, sex, all these things are temptation offers and choices, but it's not really about the plant, it's about wishes. Genie, be careful what you wish for. You know the way the genie gives you those first two wishes and then the third one's the gotcha? That's where we're at now. We're at that gotcha moment, because if you don't be careful what you wish for, watch out what happens. Science and reason really do matter. Thanks for your time.